Assalamu alaikum. You all can hear me?
Yes, sir.
Yes, sir.
Okay. So, on the behalf of Pakistan Society of Anesthesiologists, Karachi chapter, I welcome you all in today's PSA online lecture series. The topic which is going to be discussed today is very important, not from the clinical point of view, but also from the examination point of view. And the topic is anesthesia for patients with hemoglobinopathies, with a special emphasis on sickle cell disease. So before we proceed, I will request you all to please turn off your microphone. And if you have any question, you can send that question in the chat box. And please ask the question in English because we have our few of our other colleagues which are from the other countries as well. So before we proceed, let me introduce uh, of today's speaker. With us, we have Professor Dr. Rafia Tabassum. She did her fellowship in anesthesiology. She did her um, certification and master's in health profession education. She did her PGD in bioethics. Currently, she is working as a professor and chairperson in the Department of Anesthesiology and Surgical ICU and Pain Center in People's University of Medical Health Sciences for Women, Nawab Shah. She has a special interest in medical education, ethics, and pain. We welcome you, Dr. Rafia.
Thank you, Dr. Azhar, for a nice introduction. Assalamu alaikum all. And I'm very thankful to the team of PSA online sessions who has invited me for this talk. So these are going to be the learning objective for my today's session, that I want you to understand it completely, that sickle cell disease patient, they require a multidisciplinary approach during the pre-operative period and also optimization of the patient before undergoing surgeries. You will also understand what are the recent updates about the various aspects of the perioperative management and what are the key components for the provision of safe anesthesia care in these patients. I have no conflict of interest to declare. Let's start my talk with a clinical scenario. A 32-year-old 59 kg Afro-Caribbean woman with avascular necrosis of right hip as a consequence of a sickle cell disease was scheduled for total hip replacement. She was referred to pre-operative clinic for assessment of her
Sorry,
condition.
Dr. Rafia, we can't hear you very clearly. Initially, the voice quality was very good, but now it's a little bit faded.
Can you hear me now?
Yeah, it's very clear now.
Oh, okay. So I'm going to start my presentation with a clinical scenario. A 32-year-old 59 kg Afro-Caribbean woman with avascular necrosis of right hip as a consequence of her sickle cell disease was scheduled for total hip replacement. She was referred to pre-operative clinic for assessment of her condition. The patient's baseline full blood count revealed a hemoglobin of 9.8 gram per deciliter, and her hemoglobin electrophoresis showed no hemoglobin A. 29% of the hemoglobin of 29% of hemoglobin F, 5.1% hemoglobin A2, and a hemoglobin S level of 60.59%. Now let's start with the presentation. Actually, as there are residents who are attending this session, I want to make it clear to them that they should know the basic of this disease. So basically, if you see the structure, hemoglobins are protein molecules which are found in red blood cells. And they functionally are responsible for the transport of oxygen from lungs to the cells of the body, and also the shifting of the carbon dioxide back to the lungs. Hemoglobin play a very important role in maintaining the shape of the RBC because they bind with the oxygen and this causes changing conformation. Hemoglobin is composed of 4 globin subunits, we all know, and mostly these units are alpha, beta, and gamma chains. Each globin subunit contains a heme group that carries iron that can bind 1 molecule of oxygen each. Fetal hemoglobin is produced in the fetus and newborns, we all know that, and it is made up of 2 alpha and 2 gamma chains. It constitutes about 85% of the hemoglobin at birth, and then it falls to about 1% of the total hemoglobin by the 1 year of age. It means it is mostly replaced by the adult type of the hemoglobin by 1 year of age. And these beta chains, they start to synthesize just after the birth and they gradually replace gamma chains. That's why the fetal hemoglobin is replaced by the adult hemoglobin. And this all is genetically controlled. My today's presentation is basically based on this article. These are the recent guidelines which are provided by the Association of Anesthetists. First of all, we should know what are the hemoglobinopathies. Basically, the disorder of abnormal hemoglobin synthesis is known as hemoglobinopathies. And the most common hemoglobinopathies, they are thalassemia and sickle cell disease or triad. They occur either due to the structural defects or due to the quantitative defects. Structural abnormalities, basically, they are caused by the alteration in the polypeptide sequence, and that will cause the alteration in the molecular structure of the hemoglobin. Then resulting hemoglobins, they are either hemoglobin SS, which is the homozygous type. We will discuss in a little while. It could be hemoglobin triad, in which one hemoglobin adult is present, a normal hemoglobin gene is present. Other is the hemoglobin C type disease, or it could be hemoglobin E type disease. These are the structural abnormalities. Other type are the quantitative abnormalities, which occur secondary due to the decreased synthesis of the globin chains. It could be decreased alpha globin synthesis. It could be decreased beta globin synthesis. So there are two types of these are the thalassemias. They may be beta thalassemias and alpha thalassemias, which are caused by decreased rate of globin chain synthesis. When we talk about the whole world, then over 30 million people from these 163 countries, in a recent study, it is said that they have sickle cell disease. So the incidence is very much high, and it is more high in the people from the Africa, from Middle Eastern and Central India. So, and there are various variants which are present. You can see over here in this slide that the normal adult hemoglobin basically is clustered on the chromosome number 11 and chromosome number 16. Whether the globin chains, they are alpha, they are beta, or they are gamma, they are present in these two chromosomes. Alpha, basically, it is related to chromosome number 16, while beta, gamma, and delta, they are present on chromosome number 11. This abnormal hemoglobin S basically is caused by replacement of the glutamic acid by a hydrophobic amino acid at position 6 of the beta chain. And that will result in the formation of an abnormal hemoglobin known as the sickle hemoglobin. This whole process is basically genetically controlled, and the gene is expressed is known as the HBB. Sickle cell disease is also known as sickle cell anemia. It's an inherited condition which is inherited as an autosomal recessive disorder, in which the red blood cells, they basically distort their shape and result in a crescent shape due to the presence of that hemoglobin S. These abnormal RBCs, when they passes through the microcirculation, they become clumped, and that's why there is going to be breakdown of these RBCs. That will lead to a shortened lifespan of these cells because of their abnormal sickle shape. And these RBCs, basically, they are inflexible. In a short while, when we talk about pathophysiology, we will see what is the thing that make them inflexible and easy and prone to break. So these abnormal red blood cells, they will cause clumping of the RBCs in the blood vessels. And this happens in various sites at the microcirculation of various vital organs, and that will cause the major problem in this disease. Sickle cell disease, basically, it is a multi-organ and chronic disease. And patient with the sickle cell disease, they experience extensive red blood cell sickling. And you can see on the screen that basically it is made up of three components. There is painful vaso-occlusive crisis that can cause chronic hemolytic anemia. And finally, there is acute and chronic end organ damage. So it is going to affect almost all the organs of the body. When we talk about the different genotypes, so basically it has homozygous and the heterozygous. The most common type is the homozygous, in which there is inheritance of the sickle cell gene on the both of the chromosomes. While when it is found in combination with the co-inheritance of the sickle cell gene with another mutant genes like C gene, or it could be E, it could be O, then it will produce a heterozygous pattern. So heterozygous pattern diseases, there are so many, and we will discuss them one by one. While the most common type you can see over here is the hemoglobin SS disease, that is known as hemoglobin sickle cell disease, or it is the sickle cell anemia, in which the 90% is the hemoglobin S, and only hemoglobin A is not present at all, and the hemoglobin A2 is less than 3.5%, the fetal hemoglobin is less than 10%. When it is present in combination with the beta gene, then it is known as hemoglobin sickle beta 0 or beta plus thalassemia. Then what is sickle beta plus thalassemia or sickle beta 0 thalassemia? 0 indicates that the blood has no normal hemoglobin, not at all. While when we talk about sickle beta plus thalassemia, it means the normal hemoglobin is present, but in a very reduced amount. So this is the difference between sickle beta 0 thalassemia and sickle beta plus thalassemia. You can see there over here that majority of the cases, they are either homozygous sickle cell anemia, or they are when the hemoglobin S is combined with the beta 0 thalassemia. So most prevalent are these. And when we see the rate of complication, then they almost share the same percentage of the complications. The severe diseases are these two, you can see over here, and also they are the more prevalent. Even in a study that was carried out in UK, the most prevalent was sickle cell disease and followed by the other one. Now regarding the pathophysiology is very important. Whenever there is deoxygenated, then this hemoglobin S molecule becomes polymerized to form the polymerized bundles. And this was called distortion of the normal shape of the RBCs. And it will cause sickling of the RBCs. It will result in decrease in the blood flow and aggregation of the sickle RBCs. And these are not only going to be there's not only stasis of the blood, but they will also cause attraction of the platelets, neutrophils, and endothelial cells. And this will further deteriorate the flow of the blood and lead to stasis of the blood. This is when these crescent-shaped RBCs, along with the platelets, along with the endothelial cells, along with the platelets, they will occlude the microvasculature in the vascular bed of the various organs. Then this is known as the vasoocclusion. And this vasoocclusion, basically, it promotes ischemia and deperfusion injury. And this ischemia will further deteriorate the changes, and it will cause involvement of the various systems in the body. And because of this polymerization, the half-life of the sickle red cell, it is going to be reduced. The normal half-life of these cells, it is 120 days, while the sickle cell disease, it is reduced 10 to 12 days. So it will produce a chronic hemolytic anemia, but in response to the chronic hemolytic anemia, there is hyperproliferation of the bone marrow and hyperdynamic circulation. The same pathology can all easily be seen over here, that whenever it is the hemoglobin S is going to be exposed to reduced concentration of the oxygen, then it will cause in the formation of the polymer bundles. These are the tectoid, known as tectoids, and it will not only distort the shape of the RBCs, but it will cause their hemolysis when they will pass through the small vessels into the body. It will impair the flow. It will it will attract to other cells, and finally an inflammatory process will start, which will cause release of the various inflammatory and pro-inflammatory mediators and causes further damage. When we talk about the clinical presentation of this disease, so this is a multi-system disease, so it involves almost all the systems of the body. In the neurological presentation, the most important, which is seen in 50 to 70% of the patients, it is the cerebrovascular accident. And in children, it can reoccur within 3 years of age. Other are the proliferative retinopathy, blindness, painful crisis, and peripheral neuropathy. If the child is going to school, then they show very poor school performance. When we talk about the cardiovascular system, then conduction abnormalities are seen secondary to the iron overload because of the repeated transfusion. Hypertension, cor pulmonale, and left and right ventricular dysfunction is also very common in these patients. Regarding the pulmonary system, as we will talk about the most common complication, that is the acute chest syndrome in these patients. The initial findings are basically pulmonary infarction, pulmonary fibrosis, and pulmonary hypertension. In these patients, airway hyperreactivity is very common. So you must consider it when you are planning for the general anesthesia. Restrictive and obstructive lung diseases are other hallmarks of this disease. When we talk about the genitourinary problems, then hematuria, proteinuria, and chronic renal insufficiency along with renal failure is also seen in this patient. If the child is male, then Tabassum is another complication which is very common in these patients. GIT shows the highest incidence of the cholelithiasis in 70% of the patient. And when these patients come to our preoperative clinic for assessment, most of them, they are ready to go either cholecystectomy or splenectomy. So in GIT, acute hepatic syndrome and cholelithiasis, they are very common. In addition to this, hepatopathy and cirrhosis, they are also not uncommon. Another acute emergency that can happen in these patients is the mesenteric ischemia. That is very devastating. In musculoskeletal system, as the case scenario I presented initially, avascular necrosis is very common along with the osteomyelitis, and usually osteomyelitis is caused by the gram-positive organisms. Regarding the hematological system, there is autosplenism along with the aluminization due to repeated blood transfusions, sequestration crisis, hemolytic and aplastic crisis. They are very important in these patients. And if we are discussing the obstetric population, then there are chances of demise of the fetus and premature or IUD babies. It is very common. What are the methods to detect basically this hemoglobin? There are various methods are used, but we are very much familiar with the capillary electrophoresis. Remaining are the flow cytometry or mass spectrometry, or even high performance liquid chromatography. They are in use. If we talk about the different types of the sickle cell crisis, then the residents who are attending, they will be very interested to know about the various crises that happen in these patients. The most famous is the vaso-occlusive crisis, which is very, very highly fatal. It can be. It is occurred because of the obstruction of the microvasculature, and the most common is the acute chest syndrome. That is very, very important because it is an acute pulmonary complication of the patients who are suffering from vaso-occlusive crisis. And it is defined, acute chest syndrome is defined by the finding of a new pulmonary infiltrate involving at least one complete lung segment on the chest radiograph. It is not due to the atelectasis. So basically, patient presents with the fever that is around about 38.5 degree, coughing, wheezing, tachypnea, chest pain, and usually hypoxemia, which is less than 92% on the room air. Pleural effusions, they are also very commonly seen on the chest radiographs. If we talk about the causes of the acute chest syndrome, so basically it is a triangle. It can be caused by the pulmonary infarction. It could be caused by the infection. Infection may be viral, bacterial, chlamydial, or mycoplasma. And the third is involved in the etiology is the pulmonary fat embolism. And this fat embolism basically comes from the necrosis of the bone marrow. So it is a very common acute chest syndrome is a very common post-operative complication, and these patients should be monitored for this complication in the post-operative period. So, and it is also a very common cause of death in the patient of the sickle cell disease. It can be prevented by giving judicious hydration, effective analgesia, and use of incentive spirometries. And if the risk of acute chest syndrome is very much high, or it has happened, then the role of exchange transfusion is very important. Another type of the crisis is splenic sequestration, in which there is sudden pooling of the blood into the spleen, leading to acute hypovolemia, and it can be managed by giving adequate circulatory volume, and it will causes restoration of the circulation. In aplastic crisis, the anemia that is caused by the viral infection, usually it will cause cessation of the bone marrow activity. So basically, the blood transfusion is the same answer, is going to be the answer. In hemolytic crisis, which occur due to the red cell destruction, will lead to sudden decline in the hemoglobin. And it is usually seen in the patient with G6PD. Again, the answer is going to be the blood transfusion. Now, what are the different current therapies which are available in these patients? So, the current therapies include either the use of the hydroxyurea, that is known as the hydroxycarbamide. It is basically a cytotoxic drug which is mostly used in the management of the leukemia. But in these patients, the hydroxyurea causes decrease in the hemoglobin S polymerization. It will also improve their RBC lifespans, causes improvement in the red blood cell hydration, decreases the concentration of the hemoglobin S, and it will improve the flow of the RBCs. And thereby, another very important mechanism of action, if we talk about hydroxyurea, is it will increase the nitric oxide, and that is a potent vasodilator. So vasodilatation will improve the blood flow. Then if we talk about the problems that can happen with hydroxyurea, it can cause an allergic reaction, it will disturb the liver enzymes, it may increase the creatinine, and it can cause malignancy or skin ulcer. So it should be used cautiously in patients who already have liver disease disturbances or renal impairment. While the genetic therapy, they are the future treatments which are still under investigation. Now, our portion starts. How we are going to manage this patient in the perioperative period. Basically, it is as I said earlier, it is a collaborated or multidisciplinary team that is going to be involved in the perioperative care of these patients. And it not only involves the anesthesiologist, but the surgeon, the operation theater staff, recovery room staff, primary care physicians, and also the consultant hematologist, who is well experienced in the management of the sickle cell disease. Adequate counseling in these patients is very important, because it will not only reduce the anxiety and stress of the patient about the surgical procedure, but it will also give patient time to think about the surgery, various options available for the anesthetic management. And during this perioperative management of the sickle cell disease, the most important is that we will take special steps to avoid the triggers that can trigger a sickle cell crisis, rapidly it will rapidly reduce the hemoglobin S level. And of course, it will avoid the iron overload also. And in patients who are actually requiring chronic transfusions, this is the best way for the correction of their acute states. Then comes a very important question. What kind of the anesthesia need to be used? So basically, in general, whatever the anesthetic technique is used, it should minimize exposure to hypoxemia, hypercarbia, acidosis, hypothermia, and hypovolemia during surgery. Care with the positioning is also a very important factor to minimize venous stasis. Respiratory depressants, they are need to be avoided. Intubations, they are usually performed after the paralysis is achieved with a short-acting agent. During induction, the steps should be taken to avoid breath holding or struggling or laryngeal spasm. The relative safety of general anesthesia as compared to regional anesthesia in sickle cell disease patient is still unclear. But there are certain studies which prove that general anesthesia is much more safe than the regional anesthesia in these patients. Even in the studies conducted by the cooperation study of sickle cell disease, the same is being said. Now, perceived benefit of general anesthesia, if we see that it includes controlled ventilation, avoided of the vasoconstriction, because the vasoconstrictors are usually used in the regional anesthesia to improve the lower blood pressure. While general anesthesia in patient, it carries a risk to the routine obstetric patients also, because in the obstetric population, we come across with the difficult airway. In addition to that, they are suffering from anemia and they are need of the blood transfusions. So if general anesthesia is required, oxygenation should be optimized with a ramped position and high flow nasal oxygen before intubation. Then on the other hand is the regional anesthesia. Regional anesthesia also has various advantages like peripheral vasodilation secondary to the sympathetic block. It will improve blood flow to the extremities, thereby limiting the possible devastating consequences of vasoconstriction. In the post-operative phase, regional anesthesia will provide analgesia. It will also help to improve the oxygen demand that is caused by the pain or the shivering. And the third advantage of regional anesthesia is that there are, as I said, that there are skeletal abnormalities, and that can there may be a difficult intubation in these patients, so that will be avoided. But regional anesthesia is associated with hypotension and hypoperfusion. How to counteract these problems? It can be counteracted by a careful technique, and very small doses of the vasoconstrictor can be used if really required. Otherwise, they need to be omitted. Then if we talk about the other considerations, there are also very important other considerations in which the anesthesiologist is involved. Anesthesiologist basically assesses the patient's perioperative risk and fitness for the surgery and plans anesthesia accordingly. So in these patients, the risk categories should be identified. Surgeries are maybe high risk surgeries or moderate or low risk surgeries. They need to be identified because on that depend the intraoperative blood loss and the incidence of the postoperative complications. In these patients, basically open surgeries, they are not as preferable, but the laparoscopic cholecystectomy or laparoscopic splenectomy, they are preferred over the open surgeries. Now, how the risk assessment can be done? Basically, first, depending upon the type of the surgeries, then the patient's history of stroke, acute chest syndrome, if the patient is having obstructive sleep apnea, or adverse reactions to the sedations, or if there is history of the venous thromboembolism. Whenever the history of all these complications is present, it means there are increased chances of the post-operative complications. So obstructive sleep apnea screening is essential in these patients if the history suggests. Risk of cardiovascular event is often assessed using various validated models like revised cardiac risk index. Patient on high risk of the cardiovascular problems, they usually have a history of the cardiopulmonary diseases also, like pulmonary hypertension or cardiac symptoms. And or the patient who have undergone in the past with the cardiopulmonary bypass surgeries, because most commonly these patients, they are coming for the surgeries like cholecystectomy or splenectomy or cardiopulmonary bypass, surgeries concerned with the ENTs, or like surgeries which involve like cesarean section, with which every anesthesiologist is routinely encountered. Then comes the use of the arterial tourniquet. It is a very controversial one. Tourniquets, they have been used successfully in the sickle cell disease patient with acceptable or no complication, while paying meticulous attention to the preoperative assessment, preoperative preparation, and intraoperative management. Still, it is controversial. When I have gone through the literature, then I found some studies which are in favor of the use of the arterial tourniquet, but other they were suggesting that it should be avoided until and unless it is clearly indicated and the hazards are less. If we talk about contrast imaging studies in these patients, they are very commonly done because these patients may go under cardiac or neurological surgeries. Hyperosmolar contrast medias, which are used for in these studies, they can cause RBC destruction, they can cause RBC dehydration, polymerization, finally sickling, and that can actually cause sickle cell crisis. So it is better to use an isotonic contrast media or media with low osmolarity. So low osmolar or isotonic contrast media is much better in these patients. But if the patient is suffering from renal failure, then these radiological contrasts should be avoided at all. If we talk about the post-operative care, that is also very, very important. Because surgical complications, they are very, very common in patients with the surgical sickle cell disease as compared to the general population. Due to the increased risk of the post-operative acute chest syndrome, infections, vaso-occlusive pain crises, and I have gone through the literature and it shows 30-day surgical mortality of 1.1%. So basically, it is advised that the acute pain team should be informed as early as possible to provide adequate and effective analgesia. Now, what are going to be the options for the pain control in these patients? So there is a variety of options they are available. Opioids can be used, but with cautious, of course, because it can reduce the ventilation rate. It can cause, again, they expose the patient to hypoxia, that is the common trigger for the sickle cell crisis. NSAIDs can be used for 5 to 7 days in these patients. Other options, they can be regional blocks or acetaminophen. And in some patients, some studies, they use even ketamine. Acute chest syndrome we discuss in detail, but it need to be recognized as early as possible and then managed accordingly. So the immediate post-operative period is very critical time for this in the sickle cell disease patient. Careful monitoring of vital signs and the conscious level is very important. A clear airway should be ensured whenever possible, and post-operative oxygen therapy plays a very important role. Neuromuscular function must be fully returned to the normal before extubation. If you are not having the uh, neuromuscular device to a nerve stimulator to assess the degree of the reversal of the patient, then you can use even subjective signs like a sustained head lift for 5 seconds or strong hand grip on the command. Other important things in which should be done in the post-operative period, they include that the extubation should be preceded by 2 to 3 minutes of breathing 100% oxygen, and the supplementary oxygen should be continued in the post-operative period. Regular chest physiotherapy plays a very important role in these patients, and there should be maintenance of the intravenous fluids, and of course adequate analgesia is mandatory. Post-operative fever is another alarming sign. You must consider it as alarming first sign of the acute chest syndrome. So prompt identification and then management is essential in these patients. These are the two articles, recent articles in which the anesthetic management of the patient with the obstetric population and the pediatric population is discussed in details. And the basic line of management, they are the same, but basically in obstetric population, they have the more chances of developing acute chest syndrome. While in the pediatric population, there are more and more chances of developing the CVA. So basically, whenever these patients, they are anemic, and it should be controlled with the simple transfusions or exchange transfusion depending upon the situation. In conclusion, basically pre-operative assessment of the sickle cell disease, whether they are going emergency or non-emergency surgeries, there should be a careful review of patients' previous history. What are the known crisis triggers? Baseline hemoglobin profile is very important. What are the transfusion requirement for the patient? Whether the patient requires transfusion before surgery, what kind of the transfusion is required, whether it is simple transfusion or it is simply exchange transfusion, it should be noted and documented. Use of the opioids, they are again a question. How much opioids can be given without and how much monitoring should be done when these respiratory depressants they are given. This type of the surgery the patients are undergoing is also very important, because it will inform the anesthesiologist that how much blood loss can be occurred. Excessive or reduced IV fluid administration is again a very important question mark for the anesthesiologist, because without this, he or she cannot actually go through the maintenance of the equilibrium of the fluids. So basically, each and everything should be used judicially, and risk and benefit analysis should be done, selecting whatever the type of the anesthesia is going to be administered to these patients. So these are my references, and thank you very much. Questions, please.
Thank you, Dr. Rafia. Very, very well elaborated, especially the management part. Very well. So with this, we have a question. Dr. Muhammad Arsalan Zahid wants to know about the cardiopulmonary bypass. Anything special if these type of patients have to go on cardiopulmonary bypass?
It
So is
again,
there? Yes, please.
Yeah, it again depends upon the, as I said earlier, that a pre-operative assessment of these patients is very important. If the patient is maximally optimized and you are corrected each and everything, and the hemoglobin levels, they are adequate, and the patient is transfused in the pre-operative time period adequately, whether it is exchange or the simple transfusion, then the patient can undergo surgery. But you should keep in mind that all the major surgeries like cardiothoracic surgeries or the neurosurgical surgeries, again, there are chances that the patient may suffer from the acute chest syndrome. We cannot ignore that complication.
Thank you, Dr. Rafia. Any other question? Please, if you have any query from a practical point of view or from examination point of view, please ask. Don't hesitate. Ask questions. Yeah, so there is another question. Is there any specific indication for exchange transfusion before surgery? And he wants to know about the hemoglobin levels as well.
Okay. Basically, the patients who, according as I showed you a recent article that is published in Hematology Journal in 2021, American Society of Hematology suggests that if the patient is undergoing general anesthesia and the surgery is going to last for more than 1 hour, then preoperative transfusion should be done. If the patient who is suffering or there is history of the acute chest syndrome and the hemoglobin is 1 gram per deciliter below the baseline, whatever the baseline I showed you in a chart, then automatic or manual, both red cell exchange can be done. And if the patient is suffering with a severe acute chest syndrome and oxygen saturation is less than 90%, even with the supplemental oxygen, then of course, there is no question. You should proceed with the exchange transfusion, whatever the way you want to be, whether it is manual or it is the automatic.
Thank you. Another very practical question by Dr. Arbab Jahangir. He's saying that in case of emergency like roadside accident, where we have less time for assessment or we have to proceed for life saving, what are the special consideration?
If again, you must, as I said earlier, that it is going to be a very collaborative approach for the management of this patient. Not only the anesthesiologists and surgeons, they are concerned, but the hematologist consultant is need to be involved in this. And at the trauma centers, mostly all the multidisciplinary people, they are over there. And amount of the blood, availability of the blood is also not a very questionable. It is easily available in all these trauma centers, so it can be used. But again, how much blood loss has been occurred and what you are planning to do. So so you can use hydration with the isotonic fluids, but cautiously, because on the one side, when there is massive blood loss and you are dealing you are going to correct it, but on the other hand, you may put patient at the risk of developing pulmonary edema and finally the acute chest syndrome. So rather than managing the patient, a trauma patient, in an accurate way, you may end up with the various complication or the fatal outcome.
Thank you. Dr. Mohanlal has a question. He is interested to know about the choice of analgesia intraoperatively, opioids versus NSAIDs. And he is interested to know about your practice for such type of patients.
Okay. First I will answer the first part of the question. As I said that the intraoperative, you can use opioids, but opioids should be used when there is strict monitoring of the patient, not only the oxygenation, but of the ventilatory status of the patient. Then opioids can be used, but I'm using, of course, nalbuphine, and but with very limited dose, very reduced dose in these patients. So far I only deal with the sickle cell disease patients coming for the obstetric and the pediatric population. And in obstetric population, we use regional anesthetic techniques and avoided opioids, while NSAIDs, as I said, they can be used. And a very safe practice is the use of the acetaminophen in these patients. It is found as effective as any other NSAID in these patients.
Thank you. So any other question, please ask question. Meanwhile, I would like to invite Dr. Asma Abdul Salam, who is the General Secretary of PSA Karachi chapter, to please have some words.
Thank you, Dr. Azhar, for moderating this session, and thank you so much, Dr. Rafia. I'm so grateful to you that you taught our participants about the sickle cell normalities. It's a very relevant and pertinent topic, both in the clinical practice and also it as exam point of view. And we have so many residents on board who have come from different cities and even different countries as well. So it always enhances our knowledge on, especially on the topic you have chosen, and deliberated it so well with the latest and evidence base. I'm so grateful to you that you delivered this topic. Dr. Rafia, we also have Dr. Akhtar
Dr.
Wahid Khan,
Yeah, this is what I
who's
want to
the
say.
senior
We
most
are very clear.
faculty and who regularly attends this session. So I would request Dr. Akhtar Wahid to please have few words as well.
Very well prepared presentation. I must say, it reminded me about my past. Even at the time when I was an examiner in CPSP, and of course when I was being trained in England, because at that time things were not that advanced as you can encounter now. But the lady pointed out about the teamwork. I do remember uh, such cases and cases where there is a multidisciplinary involvement. Everybody works. It's not like that. It's not my job. Go go and ask him. And so many instances have come back to my memory now in England. I'm talking about. But my question to one thing I would like to ask Dr. Saba from one thing is it's a very is Saleh Kashkeli. What is he doing there in Nawab Shah? Number one, I have a lot of fascination for him. He has been we are good friends. And the second thing is, how many cases have you actually encountered in your clinical practice?
Sir, the answer of your first question, I'm serving people at Nawab Shah, and I'm very happy with it. The answer of second question, so far I only encountered with 6 patients.
Assalamualaikum, sir. Dr. Saleh here.
Oh my, great.
Dr. Saleh.
What to do, yaar? Hey, Saleh,
Yes, sir.
I'm very pleased to hear your voice.
Yes, sir.
Very,
मुझे भी खुशी हुई आपका आवाज सुन के. And she is my first trainee, and she is professor and chairperson of my department.
I know that.
Yes.
I know that,
And
and
I'm proud of her. And she has done. She is being doing everything in medical education, ICU, anesthesia, pain, bioethics, and she is a very good speaker. It was all in front of all the audience.
yes, that's why I
Thank you,
said
Dr.
she.
Saleh, for joining us. We are also
Uh,
grateful to you that
I
you
was
also
there
joined the
from
session.
beginning. Okay, hello.
Yeah, Gigi.
Saleh जबरदस्त आदमी क्या
Thank you,
So,
sir.
thank you, Dr. Rafia. Would you like to have last comments on all the session and as a summary of your talk?
So, so far, I've only taken classes on Zoom during the COVID era of final year and fourth year MBBS. And this is the first ever time that I use Zoom to present my own presentation. So it was a good experience, though a new one. And
Yes,
thank
it
you.
was also a good experience for us as well because we have been conducting these sessions for now 1.5 years. And I'm really grateful to all my participants because they always join. And we have a good participant number of good participants. They also enjoy these sessions and we do value their feedback, whichever they give us the feedback. And at the same time, we are also thankful to our faculty members like you and others who always have been not only been willing but joined us in continuing this program as a legacy, or you can say as a continuation, because one person cannot do these kind of work. So we have a team, but it is because of the faculty members that we are continuing these sessions. So I'm thankful to you, Dr. Rafia, for joining us at these hours of day, and I'm also grateful to rest of my participants who have joined us, and to Dr. Azhar as well, who has moderated this session very well. So thank you, everyone, and with this we are ending this session. Thank you, Dr. Afia, thank you, Dr. Saleh, and Dr. Akhtar Bhai. Thank you so much.